Hello, everyone. My name is Daniel Morin. I'm Senior Consulting Editor at Circulation A&E. On behalf of our Editor-in-Chief, Dr. Paul Wang, I'd like to welcome you to this month's webinar discussion, which is led by our journal's advisory group on diversity, equity, and inclusion. Some leaders of that group are here with us, Drs. Walter Clair and Dr. Chiamvimonvat. They'll chair this meeting, and I'll pass things off to them in just a moment. I do want to remind you that this webinar is being recorded. The viewer's audio will be muted, but we want to make this as interactive as we can, so I'd like to encourage our viewers to use the Q&A window at the bottom of your Zoom window, and we'll get to as many of those questions as we can, if not all of them. With that, I'd like to pass this off to Drs. Clair and Chiamvimonvat. Looking forward to a great discussion.
Thank you.
Thank you. Good evening, everyone. Thank you so much for joining us for the Circulation A&E webinar this evening. The paper that will be discussed today is the Association of Structural Inequity and Race with out-of-hospital sudden deaths during the COVID-19 pandemic. Obviously, a very timely and important topic. We are very fortunate to be joined by two guest authors this evening, Dr. Stavros Mountantonakis, who is the first author and the corresponding author on the article. He's currently the director of cardiac electrophysiology program at Lenox Hill Hospital in New York City. He will be joined by Dr. Robert Roswell, who is Associate Dean of Diversity and Inclusion at Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's also co-director of the Cardiac ICU and the Associate Cardiology Fellowship Director at Northwell Health Lenox Hill Hospital. We have three discussants tonight. Dr. Keith Churchwell, President, Yale New Haven Hospital, Associate Clinical Professor of Medicine at Yale School of Medicine, and Chair of the National Health Equity Task Force of the American Heart Association. Dr. Oluwaseun Adeola, Cardiac Electrophysiology Fellow at Vanderbilt University Medical Center. He's a member of the CircEP Diversity Advisory Panel. And then we have Dr. Camille Frazier-Mills, Associate Professor, Duke University Hospital, who is also a member of the CircEP Diversity Advisory Panel. So with that, I would like to invite our guest author to lead off on the review of the article.
Okay, I think I got the slides finally to work. Okay, before it freezes again. So thank you again. So we all have experienced this in any way or the other, but New York City was the first major metropolitan city that was hit with COVID-19, and it was hit hard and it was hit fast. Just to give you some numbers, the first COVID-19 case was diagnosed in March 1st, 2020. And only within 30 days, we reached our peak. By the end of the first peak, at about June 2020, June 1st, we had more than 25 cases, deaths related to COVID, directly or indirectly. So needless to say that the city went in a standstill. And with that, healthcare went in a standstill. Basically, all of us were repurposed to take care of the patients who were suffering from COVID. There were basically no outpatient services. Our emergency rooms were pretty much set to any other pathology other than respiratory failure. And we just lost our contact with our patients. So even though the streets of the New York City were empty from visitors and tourists, it was full with ambulances that were run by FDNY, Fire Department of New York City, which is the main emergency service provider for the entire New York City for about 8 million hospitals. 8 million people. So for you who have actually visited New York City, the annoying noise of the ambulances, sirens, and was all we could hear day and night. So even though we had a view of what's happening in the hospitals, we turned out to our colleagues in FDNY to tell us what's happening in the outpatient setting. And what most representative of what's happening in the outpatient setting was to ask them for the number of people who were pronounced dead on the scene and were classified as cases of sudden death. Basically, FDNY classifies cases of sudden death. The case is the death that is unexpected without having symptoms for more than a few hours. Obviously, you know, the definition is a little not very strict in the setting of an emergency, but the definition hasn't changed for many, many years. So on the right-hand side of the slide, you can see the incidence of outpatient sudden deaths during the daily counts during the first surge of the pandemic. You can see an amazing average 5-fold increase in the number of people who died suddenly or pronounced dead on the scene by the fire department of New York City. You can also appreciate there is a bell-shaped curve that this line follows that kind of correlates with a bell-shaped curve of cases that were diagnosed with COVID. So there is clearly an association of cases of people who were pronounced dead at their homes with the diagnosis of COVID cases, and that distribution correlates well temporarily with COVID. However, we felt that there was also a regional distribution or regional inequity in the way that those cases were distributed. We are part of Northwell Health. It's a large healthcare system with hospitals throughout New York City and Long Island, and not every hospital was affected similarly or was seeing these cases with each other. So we went again back to NYPD, to Fire Department of New York, and we asked if they can present us this data, the counts of sudden death based on the zip codes. So on the left panel, it's the counts, the incidence of sudden deaths, outpatient sudden deaths per 10,000 inhabitants in 2019. I apologize, the numbers might be a little small for you to recognize, and the scale is such that differences in the incidence of sudden death, outpatient sudden death within its zip code is hard to distinguish, but I can tell you that there are zip codes where this incidence was 0.7 and others there were 2. In contrast, for the same period in 2020, you can all appreciate a significant mosaic of colors throughout the different zip codes of New York City. And I think, let me move to the next slide, which I think gives us the clear picture of what's happening. This is the ratio of case of sudden death, out-hospital sudden death in 2020 divided by cases of outpatient sudden death 2019 during the period of the first epidemic surge. And you can appreciate the astonishing difference in that increase between different zip codes. Even neighboring zip codes have a tremendous difference in the increase of sudden death. And on panel B, you can see that ratio that's plotted in increasing rate. So you can see that those zip codes that were affected the most had a 20-fold increase in the number of out-hospital sudden deaths, whereas a few had actually decreased in the number of those that were classified as out-hospital sudden death. Unfortunately, we didn't have individual data on those who were pronounced dead at homes or on the scene. But what we had was sociodemographic data on a neighborhood level by zip code for New York City. And we were able to retrieve this data by sourcing the US Census information from 2018 and the New York City crime statistics for the same period. So even though there's no individual data, we could kind of try to investigate possible association of socio-demographic characteristics of its neighborhood with the increase in sudden death. That's out-coastal sudden death that was noticed during the first surge of the pandemic. So that was a very comprehensive list of multiple sociodemographic data. I'm listing here those that were found to be univariate predictors of this increase. If I can bring your attention to the first column, this is the percentage that the variable is seen in New York City. On the second column is the beta coefficient that gives us information about the association, the strength of the association between the variable and the increase in sudden death. And the third column is, of course, the p-value. So the beta coefficient, the higher the number, the stronger the association. The closer the number to zero, the softer the association. Of course, negative numbers means there's a negative association. So it was to my big surprise, and I'm sure to surprise to many, that, for example, percent of poverty index under 2, meaning that percent of patients, of people, of individuals in New York City that are below the poverty line, 37%. Many times we think of New York City as, you know, Midtown or downtown Manhattan, and we neglect to say that New York City is a very diverse area, spanning for all 5 boroughs. Another striking for me was that the percent of habitats in New York City that had education less than high school, in other words, they did not graduate high school, was close to 20%. 1 of 5 people in New York City have not graduated high school, which I think is striking. And going to the beta coefficient, the highest association, again, univariate predictor with a beta coefficient of 9 was percentage of unemployed. In other words, those zip codes that had higher percentage of unemployed were more, were stronger associated with increase in sudden death. Again, staying to univariate predictors, this is another table talking about race. Again, you see the percentage of each race for all the 5 boroughs of New York City. It's a multiracial community, multiracial city we live in, with a percentage of white being close to 30%, percent of black 25%, Hispanic 23%, Asian 18%. So multiracial community, and the white, black, and Hispanic were on a univariate analysis, I would say not very strongly, but they were significantly associated with increases in sudden death. Of course, the big difference is white race alone had the inverse relationship with the increase, as opposed to black, and particularly Hispanic, that had a positive relationship to increase in death. And I think that that's the final slide. So when we put all of those socio-economic determinants in a multivariate analysis, to our surprise, the strongest predictors of that increase was education, particularly the proportion with less than high school education and the proportion of black race. The beta coefficient for proportion for less than high school was 2. If I can bring your attention to, I don't know if you see my cursor, but to this line here, that the slope represents the association between increased sudden death and percentage with education less than high school. And this beta coefficient here is represented by this slope that correlates black race, percentage of black race with sudden death. Of course, the combination of the two gives us the overall predictive model. So it was, I think, a very important finding, and Robert will continue with further his analysis. But the univariate analysis, where we found many predictors that cancel each other out, but again, on a multivariate analysis with the strongest model, education of less than high school and proportion of Black race were predictive of that increase in outpatient sudden death during the COVID pandemic. And I'll pass it on to Robert.
Thanks, Stavros. And I think when you're looking at all of these results and how do you digest them, looking really at the social influence of health or social determinants of health, which we'll talk about, and looking at race and education, when you're talking about structural inequities, I put this slide just to show the Spearman's correlation of race and ethnicity compared to one of those social influencers, which is less than education. And you can see the correlation looking at in the neighborhoods. You can see that there's a negative correlation with less than high school education with white. So the more the percentage of a population or a zip code had white, the more educated they were. And so there was that inverse relationship. And you can see here, you can see white and Asian on a certain curve in terms of the negativity of the Spearman's correlation. And you can see Black and Hispanic as a positive, that the more the neighborhood was Black, the more the neighborhood was Hispanic, there were more people who were less than high school educated. And I think looking at the structural differences, this is the second level where you have to sort of question why that is. And so we go to the next slide. You can see one of the reasons that we looked at this project in this manner is looking at total health. And do we actually address all the facets of total health, which are your physical environment, the social economic factors, and we know clinical care really constitutes a small part of total health. And so that's what we were doing with all the variables that we were analyzing. We were looking for neighborhood safety, which is why we put in the crime statistics. We were looking at the physical environment. We were looking at social support by household. We were looking at access to healthcare with insurance status, et cetera. And we're looking at socioeconomic status. And if you go to the next slide, you can see that there are a lot of social determinants or social influencers of health. And I just wanted to make the point that the reason that we term these social influencers of health instead of social determinants of health, this is Dr. Toko Bradley at Trinity Health, really came up with the term social influencer. For example, if your neighborhood was unsafe and there was a lot of violence and that affected your health outcomes, if you move to a different neighborhood, that sort of effect will be removed. And so social determinants seems like it was a very fixed sort of effect that it had on people's lives, where we think that social influencer is a better term to use because they're things that affect short-term and there are things that affect long-term, like education, but there's still remedies for that in the long term. So we go to the next slide. Education has always been pivotal in terms of affecting health outcomes. And if we look at the Institute of Medicine, talking about health literacy is one of those reasons. And I think just to define health literacy is really the capacity to obtain health information, to process it, and to understand it. And just looking at this slide, I'm looking at frontline workers and essential workers. So we know that frontline workers are people who are called to action, which are physicians, nurses, anywhere in healthcare, but other fields as well. Essential just is again, looking at people who have to come to work, but frontline people are the people who actually have to be there at work, like sort of physicians, nurses, and also people who do certain services in the hospital, et cetera. And I put this slide up just to show that in frontline workers, you can see that there's a impact of education as well. And so looking at who these people are in these neighborhoods, they're really the frontline workers who have less than high school education and their wages are low. And then you go to the next slide, what we found besides education was that Black race was associated with increases as well in those zip codes. And I think this is what Dr. Churchwell talked about, toxic stress. And so Black race in the neighborhoods and dealing with the toxic stress of racism. And we're talking about structural racism with all of these inequities, but actual interpersonal racism has been studied and showed to have really physiologic effects on blood vessels, CAD, sudden death, increase in cortisol levels, norepinephrine levels, et cetera. So that is one of the hypotheses that besides all of those structural inequities and structural racism that impacted these communities, there's also the individual or interpersonal racism that could have played a role in sort of the Black neighborhoods and Hispanic neighborhoods with increased out-of-hospital sudden death. Thank you so much for your attention, and we will turn it back over.
Thank you so much for that very thought-provoking and very important study. At this point, we would like to, Walter and I would like to invite Dr. Churchwell to provide some commentary as well as reflection on this very important and timely study. And then we'll go on to our discussion as well. So Dr. Churchwell.
Well, thank you, and thank you for the opportunity to join such an august group this evening. Interesting work. I have a few questions, and maybe I can actually hold them to the end as for the commentary, or how would you? I'm happy to sort of understand how do we want to approach this as we go forward. The ideas are that we have been discussing and actually thinking about the impact of social determinants on the overall health of the population, I think are not only timely, but extremely important. This particular example is actually an acute example. I thought it fascinating in terms of looking at your data that at the baseline, if baseline is 2019, the incidence of sudden death was actually relatively stable throughout that particular period of time. Obviously, the pandemic had a significant trigger, whether these patients died from quote unquote sudden death secondary to the COVID, or COVID actually elicited a rather atavistic response leading to the increase in sudden death is something that we should actually hopefully could figure out and discuss. But its impact actually on the populations at large was incredibly important. It's interesting that actually the zip code data was illuminating in terms of thinking about the distribution between both from a race standpoint, but also as you dove deeper in terms of the issues around a high school education and also economic capability. You look at the RWJ data from looking at lifespan data, not only in the Boston area, but across the country, and the Boston area being one of the prime examples. Zip codes that are actually next to each other, the Back Bay and also Roxbury, which are actually connected. You look at the lifespan data, it's remarkable that the lifespan actually in Roxbury is actually some 20 to 30 years less than actually in the Back Bay. I think these all correspond to the issues that you actually discussed, the issues of both social determinants and also the issue of allostatic stress that actually the population, African-American population, Latino population actually experienced within the Roxbury area. I think that's all consistent as we go forward. It is interesting, though, is that actually the trigger for the pandemic seeing such a marked increase and its ability, and whether it's the access to actually care, the understanding about the need for actually a more acute care evaluation, not having access to a care pathway for the population, whether it be from a transportation issue or with actually having a medical home issue, for them to actually work towards a better pathway for them to be acutely evaluated and hopefully put on a better path ultimately in terms of their care needs. You know, we looked, one of the big reasons from AHA's perspective that this kind of data and other data is actually support to these particular the differences. We see that ultimately leads to a significant frustration when we began the process of looking at the 2010-2020 goals, which actually was a 20% reduction in cardiovascular disease and cerebrovascular disease and overall stroke morbidity and mortality. It became very evident at halfway through that process in the past decade that we were going to achieve those goals. Looking at the data and the reason why, was that because the population that actually was being served to the greatest degree, that was actually being impacted on these particular events, was a population that actually we were having the least effect in terms of decreasing the overall risk factor profile and also decreasing the overall incidence of these particular events. That was actually in the African American community and the Latino community, the underrepresented minority community, the Black and Brown community. That actually led to a re-examination in terms of goals and how to actually achieve goals in AHA, in terms of improving the overall lives of those actually, and having less and actually removing the issues in terms of cardiovascular disease and stroke within the population, and what should be our focus. And that was actually one of the things I was asked to lead in 2015 in terms of the task force looking at health equity and social determinants, which ultimately led to actually an Office of Health Equity, and also a number of papers that have come through HA looking and determining and evaluating these particular issues and its impact across multiple populations: rural health, urban health, African American populations, Chinese American populations, Indian American populations. The spark that actually the George Floyd incident gave to us actually in May of last year was really part of this particular journey that led to the structural racism paper that came out in November that we began putting together actually the summer of 2020. And looking at the fact that the underlying issues that lead to a significant differentiation in terms of the overall health of the population, that we go back in terms of thinking about the social determinants, lie within actually the structures that have been put in place in this country, going back actually from 1619 and then going forward. And that understanding that, realizing that these are issues, working towards how we ameliorate these issues to a greater degree, is going to be incredibly important for us to actually make real progress in improving the overall cardiovascular and cerebrovascular health for the whole population, not just for the population that is informed, population that is educated, population that has access to actually high quality of care. How do we actually move everyone forward in the right way? Understanding these underlying tenets and actually working towards solutions on top of medical solutions is going to be key. I think your paper actually speaks to that. We see this. We see that actually with this particular spark, how things spread so dramatically in response to a pandemic, or actually in terms of a stressful situation, and the need for us to actually address these issues actually in a greater degree. I'll stop there in terms of pontificating, but I had a couple of questions for the two of you. When you talk about, and I think you may have been sort of hogtied a bit by the definition of sudden death and cardiac arrest, and not being able to attribute that to the pandemic itself. What's your thoughts on that? Because it seems that's an obvious correlate, but actually not something that you could call out to a greater degree.
The question was about the definition of sudden death.
Right.
So obviously there's limitations. There's limitations, especially during the pandemic, and the definitions, the documentation is not obviously as robust as during normal times, you know, it's not. Traditionally it's been thought that cardiac arrhythmias are the main factor, the main mechanism, physiologic mechanism for sudden death. Obviously, in a setting of a pandemic, we can have fulminant acute respiratory failure. You can have, patients who just did not have access on time to seek medical attention. As I said, the city was in standstill, but also medical care was standstill. We were not communicating with our patients. There was no outpatient services. There was no emergency room. So patients who would normally see the doctors at the office for worsening symptoms, they had nobody to talk to. So I'm sure that part of what we traditionally say that's arrhythmic sudden death is now a combination of acute respiratory failure or something else. However, experiencing patients with confirmed COVID infection in the hospital, those patients were also dying of sudden death. They were okay one day, and then within a few hours, they became hypoxic and they would arrest, and there was little you can do about them. So a mode of death of bradyarrhythmic more than tachyarrhythmic was very predominant on those patients. And the way the metabolic disarray was coming in these patients, they were fine one day and then an amazing, profound inflammatory response with the huge disabolic array, metabolic abnormalities, and then they would just crash. And so it's not a big surprise that what we were seeing in the hospital actually what was happening at the outpatient arena.
At the end of the day, all death is because the heart stops. So you're exactly right from that standpoint, right? Not because the kidney stops, because the heart stops. It's a good point. The other thing in terms of the discussion and your presentation, I was actually very intrigued about is this idea of influencers, the social influences of health versus social determinants. And the idea that there is a significant amount of mobility and opportunity that if you can change influencers, you can change the overall outlook for the individual, for populations. Data to support that from your perspective that you guys actually, as you went forward and went through getting the paper together, that actually shows an example of that? Because in most cases, you know, these are things that actually have happened over hundreds of years in terms of developing these particular structures. And the ability to actually have an influencer or a change that dramatically changes one's actually capability to actually improve overall health. You know, it's unusual, I think, in terms of how we think about this, but there are examples of that would be worth actually studying to a greater degree.
Yeah, Dr. Birley has an article in The Lancet talking about structural racism and health inequities, and talked about a model in the States actually moving people's housing and showing how that actually impacted health outcomes. I think the longer things like education, socioeconomic status, if that's going to change. I don't think we have a lot of data to support that your health outcomes will change, but with that particular study, there was a difference in health outcomes. And I think the more, I would call them the more proximate ones in terms of neighborhood violence or the physical environment or environmental pollution, I think that's where I think of the environment actually influencing your health outcomes. And you move out of that neighborhood, you know, that influencer just goes away, and it does not necessarily determine the rest of your life. And so there are a couple of small studies that show that example. And I think it's a frame shift to think of social influencers or just influencing instead of determining for the rest of your life what your outcomes would be.
So it'd be interesting to think about how to narrow the focus in terms of where we want to put our resources, financial, administrative, social resources, in a way that actually can make a dramatic change in a very short period of time. What are those particular triggers we'd want to actually be able to identify and say that if housing is the issue and education is the issue, making a dramatic and concentrated effort to actually move a population very dramatically into a different strata, and then seeing the impact on their overall medical health would actually be something both intriguing and important to actually understand and to evaluate. And
the last thing I'll say about this is that I was encouraged about education being the one that was most associated with out of hospital sudden death, because that actually is actionable.
Yes.
If we fix our education system and more people have high school and college education, that is actually something that we can do.
That's actually, from a generational standpoint, if we did that, there would be a generational leap in terms of the overall improvement of the overall health of the population if that were to occur. So yes, I'll stop there and happy to answer questions or add any more commentary. Go ahead.
I'm wondering if Dr. Frazier-Mills might have a question for us.
Yeah, I think, thank you so much. This is a wonderful discussion and a nice paper to bring out some really important examples of how socioeconomic status and race in education really influence outcomes, particularly during a pandemic when there are such dramatic differences. A couple of things that we were thinking about is, one was the sources of your sociodemographic data. When you're looking at your zip codes, you use the Census Bureau data, which I think we've seen in a lot of different studies. But one thing that you did that was a little more unique was looking at NC crime statistics. Can you tell us the role or what variables you picked up from that? Is that
Yeah, absolutely. And I think as we're talking about in terms of the crime statistics, we were looking at that variable to really describe the neighborhood in terms of its physical environment and neighborhood safety as a social influencer. And so to see if that actually had some impact. And I think doing this population study and looking at these large variables of unknown impact, we thought that would be an interesting and unique sort of vantage point, and to try and get as comprehensive as possible all of these social influencers or social determinants or social demographic factors, and to see how they actually impact out of hospital sudden death. So that was the reason that we did that.
okay? Great, thank you so much. Another one that we wanted to ask about was the Gini index. Can you give us a little more information about that?
Yeah, so the Gini index is it's a measure of wealth or sometimes income inequality. And I think the Gini index, as they was studied in the United States, is more income inequality. So we were looking at not only the socioeconomic status in terms of your median income, but if there's a lot of income inequality between zip codes, which, as Stavros pointed out, is there in New York City. You could have someone who's making millions of dollars next to someone who's in the next neighborhood over making $20,000 or $30,000. So we're seeing how income is distributed and whether that actually impacted. So that's what the Gini index is for. And one is where there's perfect sort of income inequality, and zero is when there's none. And so you actually can get that sort of specific data on zip codes in terms of income or wealth inequality.
Those are great. One other question that came to mind, and I know you showed us a little more data today, and looking at in these particular zip codes, do we have a better idea, at least that wasn't necessarily presented in the paper, of essential workers in the zip codes? I think you gave a little more information on that in your presentation, but can we nail that down anymore?
Yeah, so unfortunately, we don't have the individual patient level data, but we have the demographic profile. And so what I was presenting earlier in the PowerPoint is who frontline workers are versus essential. And essential basically is the catch for most people, and frontline are the ones who have to take care of patients and also have to sort of do the other task. And that's such a diverse population. Because you have higher end people in terms of socioeconomic status, and you have lower end, and it shows in that particular figure that the frontline staff tend to be people who have less than high school education, lower wages. But again, we didn't have patient specific data, but it just matched the profile in terms of demographics. So that was just an association. And some of the limitations of doing sort of population-based, community-based analyses.
Great.
Yeah, thank you. I think given the database that was used for the study, I think you guys did a very good job in terms of organizing this study. I really give a lot of credit to you guys for that. I think one of the things that was striking to me was the fact that during the COVID-19 peak, the period that you studied in March and April, if you compare that to 2019, where the out-of-hospital sudden death rate was relatively flat during that time period, there was an upsurge in out-of-hospital sudden death during that time period. And it's always interesting to see how they base the direct interplay in the incidence of COVID-19 in these particular zip codes. Compared to the rate of death, and how those particular zip codes, how they were directly influenced by the surge in COVID-19. Does it have something to do with the behavior of the people that have less than high school education that make them more likely to die suddenly during that particular period, or what are your thoughts on that?
Yeah, I think that's a great question, and I think thinking about health literacy versus the behaviors of those people in those particular zip codes. And I think education, first of all, like Dr. Churchwell mentioned, education is associated with so much. right? It's associated with social capital, it's associated with employment, it's associated with so many things. And so, you know, that education, I think, is really a driver for a lot of things that went unmeasured, even in all of the variables that we had. And so if you try to relate education and health literacy, I think you have a direct connection there. But health literacy also means the ability to access medical care, that you know how to access medical care, and you're not confused about that, and you could actually understand, well, what physicians or healthcare providers are telling you. So I think there is something with the less than high school educated that goes beyond sort of interpretation of medical data. It probably also has to do with access to medical data, access to hospitals. You know, if we go back to the pandemic, many people who have questions, who have relatives who are physicians, can call somebody up and ask them, do I need to go to the ED? I think people in these zip codes and these under-resourced communities just didn't have that access. And this is what Stavros was talking about, that in the pandemic, everything had changed in terms of healthcare delivery models. And these were our most vulnerable. And I think the less than high school education is just associated with all those things. And that's why we have those outcomes. And, you know, we have the social vulnerability index, which sort of predicts this as well, that if there's a pandemic or some strain to people, they would fall to those strains. And I think education and its associators are a prime example of that.
You know, Sean, that's such a great question, because in actuality, I think what you discovered or actually uncovered is that there was a fire going on underneath that was actually being suppressed. It was actually just a coal fire, but then kindling actually was then given to the fire. There was starter fluid, and that was the pandemic, and that just let it erupt, and then just uncovered the issues that actually leads to actually poor health outcomes, actually, and your data actually points towards actually detailing these particular issues to a greater degree, but that the pandemic was the kindling that made the fire erupt and really uncovered. I bet if you had the opportunity to look at data from Los Angeles or data from other, you know, Boston or other centers, you probably would find very consistent data, right?
Yeah.
That would actually
Absolutely.
for us to really understand that this is not an acute situation. This is actually a chronic issue that actually a pandemic or something else. It could be actually another both natural disaster or actually a functional disaster that occurs to a community that actually would show itself with these kind of results.
Yeah. And he also speaks to the, go ahead.
No, I was just going to say, I think particularly if you're looking at the social influencers or determinants, there's so many of them. And I think one of the reasons that we wanted to do this study was to see if we could figure out which one had the strongest association or the biggest impact that can guide us towards some sort of intervention. Because the survey data that we had, there's about 150 variables. And still that's not even enough because we could dig even deeper. And so I think just showing, again, what we can do in terms of which one is most impactful, I thought was a real strength to our analysis. But I interrupted you, sorry, go ahead.
Yeah, no, it was just in the same line. It's just not just about the effect of COVID itself, but the response of the healthcare providers in terms of alleviating the effects of COVID. Like, how do we allocate resources? Are resources diverted even further away from this low resource zip codes to zip codes where people are more educated, more employed? How are the hospitals that normally have their base in Manhattan, for instance, and have satellite campuses, how do they reallocate their resources to deal with the COVID-19 surge? It's one of the things that makes one wonder. These are the things that further exaggerated the effects of the pandemic on the outcomes that we see. And I think that your paper beautifully highlighted that. I mean, how the discrepancy sort of played in the response of to the COVID-19 itself.
Sean, it's interesting. I'm sorry. Go ahead.
What I'd like to point out, I think that it has been mentioned multiple times before. It's not what's the mechanism of outpatient sudden death, whether it was arrhythmic or not, that we discussed before with Dr. Churchwell. That's not the point of the paper, I think. It's, you know, the zip codes that had higher out of hospital sudden death before the pandemic had also the higher incidence of sudden death during the pandemic. But the difference between those who had higher than those who had lower was exacerbated to a degree of, you know, tens or 20-fold. As a matter of fact, those who had the lower incidence of sudden death during the pandemic had even lower, because those citizens who were staying there were able to leave New York City and go to other areas. So, you know, there's a dynamic of ability to react in a crisis that's what we're looking at. How a crisis, it could be COVID, could be anything else, how a crisis can exacerbate this inequity in accessing care, in delivering care. This is what the paper is about. That's why we focus on the difference rather than the absolute number of cases.
When we talk
Well,
about
if you were to
resources, I
have-
wanted to make the point that
sorry.
one of the challenges with trying to correlate this increase in sudden death with the actual spread of the virus is the fact that early on, and you were early on with the first wave, one of the things that many people were complaining about was that testing was not done in the targeted zip codes that you've identified. So to some extent, we were hamstrung by the fact that we wouldn't have known if the infection rate was higher and correlating with this spike, because these were the people who were not being tested. They didn't have access to testing centers. So my question is, do you have data to show you that this pattern recurred later when you had your second surge in the city? Or are you planning to look at that?
I think that's a good question, and I think we can look at the data to see if it recurred as well. I think there was another part of the data set where we actually looked at the cases and the cases that were actually diagnosed, and it looked at a similar curve to what we showed in terms of the out of hospital sudden death curve. So they were actually almost sort of interposable. And so I think that is a great idea to look and see if this same sort of cycle has repeated. And, you know, as we were saying before, I think it sets up a strategy for intervention, because if healthcare delivery systems and hospital systems have their way of delivering care and this affected the most socially vulnerable patients, we have to change the structure of that healthcare delivery model.
Mm-hmm.
And I think that's something that we can interrogate and something that we can do, because I have a feeling that there are other pandemics and disasters to come, and we don't want to continue to see these disparities in terms of how certain people are affected and others are, we can say, protected.
You know, Robert, I do think that your study was, first of all, it was fantastic. And second of all, I think that you're right that you're pointing out sort of populations who are more fragile, who are more likely to be stressed to a greater degree than others, stressed sometimes to the breaking point, unfortunately, resulting in sudden death. Other factors, though, of course, also go along with, as you're pointing out, and as Dr. Churchwell was pointing out, other factors co-vary very closely with education, things like smoking and exercise and diet, et cetera. So I think that you've sort of maybe touched upon the common factor that binds all of these things together, and I think it was very nicely done.
Thanks. And I think, and you know, just to talk about education and health literacy and all those things, these are things that have been published for a while in social science journals and health equity journals, that education is the key. And education in your zip code are, we think, the biggest determinants of your health.
Let me make a comment, and then I want to ask Dr. Churchwell a couple quick questions. The comment is this. So there is a study. I can't give you the exact reference that looked at this issue of education here in Nashville. It's a 10-year study that was just published, and they looked at African Americans who moved to highly affluent areas. Those of you who know Nashville know that we have a community, Brentwood is a highly affluent area. And what they found was that when you looked at healthcare parameters, it is true that better education and better income improve one's health status. But for African Americans, the effect was minimal, at least in that first generation. That getting that education and getting that good income and living in that environment still didn't have nearly the magnitude of improvement in one's health status that occurred among non-African American populations. And so it worries me that we think that if we just fix the educational system, we don't have to fix all the other structural stuff that's out there. Because even college educated African Americans end up getting lower paying jobs. The women still have high rates of loss of their babies when they get pregnant and so forth and so on. But given our time, I want to just ask Dr. Churchwell, in light of the fact that you were the first author on this what I consider to be this wonderful AHA presidential advisory. My question is, has there been pushback? Because one of the things that I've experienced and others have worried about is that as we have looked at these social determinants of health, and as we looked at a call to address structural racism, there's been a little bit of pushback from people. And there have been people who've kind of said to the athletes, for instance, that they need to stay in their lane. I'm wondering if you and AHA are hearing from people that the AHA needs to stay in its lane and stop addressing these social determinants of health.
Well, it's a great question. Two-part answer. I want to just address what you said before, which I think is actually incredibly important. One of the reasons that this paper, one of the other reasons this paper evolved is actually the AHA looked at their own data. All of actually the work that had been done in terms of overall primary prevention, and seeing actually over the past 10 years, not a small actually improvement, both across the population in terms of reduction in cardiovascular event rate, morbidity, mortality. But the difference between the Caucasian population and our Black and brown communities was still strikingly large. 44% actually difference in actually morbidity and mortality for stroke, and greater than 30 and actually for cardiovascular disease. So it really speaks to an underlying structural issue that I think is important that we have to really understand, and understand how do we actually break down that overall structure, ameliorate it in a way that moves us forward. You asked the question about what's the impact on AHA in terms of the paper, and also the initiatives that have come to the paper. AHA actually has a 10-point policy initiative in terms of from the outcome of the paper that speaks to, this is an example, the science of understanding the issues that surround structural racism, the issues that surround the differences in populations in terms of the overall health, investing in human resources and business operations for AHA to actually make it mirror what's the best in terms of practice that we can move us forward, and actually leadership in this addressing this issue. You know, from my perspective, and what I have heard is actually remarkably positive response to this paper. Many institutions and many individuals and institutions are using an example of how they want to go forward in terms of having the right dialogue and structuring their responses to the issues that surround us to a greater degree, giving them some degree of cover, right? Mm-hmm. As an institution of actually coming out in this particular way, addressing the issue rather straightforwardly, and asking ourselves to actually start bringing more solutions to this problem. So I think that's been very positive. I have to talk to others in terms of thinking some of the other commentary that came out. One of the things that actually we did as the paper evolved was that we did send it out to multiple individuals who actually have had relationships with AHA and actually are very much within our field, people you would know very well, and asked for commentary. And we did get a couple of commentaries that the paper was too striking, that we needed to tone it down. And we did do a bit of editing from that standpoint to actually understand that. But the other response was, for many people, was it needs to be more striking. You need to get more out in front in regards to this, because this is the time to actually, if we're going to make a move around this, as we talked about before, making a move in terms of making impact on the populations that we serve in a way that makes a difference, whether it be education, whether it be opportunity in terms of looking at the needs of populations for housing, transportation, and nutrition, and then applying those particular ideas and opportunities in terms of true risk factor reduction, smoking, obesity, hypertension. This is the time to do it. We're not going to actually, if we wait too long, we won't actually have an impact. If we don't actually start gathering resources, we don't have an impact. What's come from this exactly is about a $25 to $50 million investment from actually both AHA and from outside resources to go into local communities and help actually identify these issues that Robert and Stavros have talked about, and bringing solutions about and to actually be the test of change in regards to those particular investments. And also, other opportunities that are aligning themselves across all of AHA, every single part of it, whether it be the scientific community, whether it be the social activity community, the advocacy community, which actually I'm a chair of. We've worked to align ourselves based upon this paper and actually upon the tenets of both the 10-point goal and the 2024 goal to say these are the solutions. We have to bring solutions to this problem, because if we don't, we won't actually get to where we really want to be in regards to all this, right?
Well, thank you very much for that. I think our time has run out. I'd love to thank all of you. This has been a great discussion. It's really been a primer, frankly. I want to thank our paper presenters for doing this work. I know it was a challenge for you under very challenging circumstances. I want to thank our editors for allowing us this time. I want to thank my panel members and discussants. And I want to thank you, Dr. Churchwell. I know you have a very busy schedule, and it was very delightful for us to get the view from the leadership of the AHA. I really feel that the presidential advisory did give us cover, and that's an example of what leadership can do for those of us who are on the front lines and want to get some of the work done.
That's all right.
Thank you all very, very much.
Got thick flak jackets, Walter, as well. The opportunity to being a part of this. Fantastic. I really appreciate it. Thank you.
Thank you so much. Everyone have a good evening.
Thank you, everyone.
And go Vanderbilt.
Bye.
Night.
Thank you very much.
Thank you.
Night.